Today we should be looking at diabetes in pregnancy. Pregnancy places demands on the carbohydrate metabolism and causes insulin requirements to change. In the first trimester, the pregnant client's insulin needs decrease, and in the second and third trimesters, this increase in placenta hormone causes an insulin-resistant state that requires an increase in the client's insulin dose. There is an insulin resistance that develops at 16 weeks due to an increasing in the production of the human placental lactogen hormone. This human placental lactogen is an insulin antagonist that is produced by the placenta, decreasing the maternal glucose metabolism in order to increase its availability to the growing fetus. After placental delivery, the placenta hormone levels abruptly decrease and insulin requirements decrease as well. Gestational diabetes occurs in pregnancy, usually in the second and third trimester, in clients who do not previously have diabetes mellitus. Pregnant clients should therefore be screened for gestational diabetes between the 24th week and 28 weeks of gestation through a 1-hour glucose challenge test. The client's glucose normally crosses the placenta, but insulin does not cross the placenta. Therefore, newborns may be large in size, what we call macrosomia, and they may be at risk of hypoglycemia, hyperbilirubinemia, respiratory distress syndrome, hypocalcemia, and congenital anomalies that are associated with high levels of glucose in blood. When making a diagnosis, we use a glucose tolerance test where we have two types of the same: a 1-hour oral glucose tolerance test, which is performed between 24 and 28 weeks, and a 3-hour oral glucose tolerance test that is performed if the result of the 1-hour OGTT is abnormal. A glucose tolerance test is indicated in screening for gestational diabetes mellitus, and normal findings at 1-hour oral glucose tolerance test should be less than 140 milligrams per deciliter. A 2-hour oral glucose tolerance test should show a fasting blood glucose levels less than 95 milligrams per deciliter, and after 1 hour, the result should be less than 180 milligrams per deciliter. After 2 hours, it should be less than 155 milligrams per deciliter, and lastly, after 3 hours, it should be less than 140 milligrams per deciliter. A diagnosis of gestational diabetes mellitus is made if at least 2 of the 4 blood glucose level measurements are abnormal. What are the nursing interventions that we need to put in place when carrying out these glucose tolerance tests? During a 1-hour glucose tolerance test, a client is instructed to drink 50 grams of glucose solution, and a blood level will be measured 1 hour later. If the blood glucose level is 140 milligrams per deciliter or higher, the client will have to undergo a 3-hour oral glucose tolerance test. In a 3-hour oral glucose tolerance test, a patient is instructed to fast for at least 8 hours before the procedure. A blood sample is then drawn to measure the fasting blood glucose level, and this patient will be given 8 ounces of glucose solution, that is approximately 100 grams, to be taken by mouth, and a blood glucose will be then checked at 1 hour, 2 hour, and 3 hours. What are the assessment findings in gestational diabetes? As with diabetes, we will be having the 3 P's: the polyphagia, polydipsia, and polyuria. These patients will be having hypoglycemia usually in the first trimester, and hyperglycemia tends to develop at the second and third trimester as the amount of insulin needed increases. These patients will be experiencing weight loss, glycosuria or glucose in urine, and ketones in urine known as ketonuria. They'll be having a blurry vision and a recurrent urinary tract infections and vaginal yeast infections. These patients as well will be presenting with polyhydramnios, a large for gestational age fetus, and increased incidence of preeclampsia and infection. Some of the risk factors that are associated with gestational diabetes mellitus are an older age of more than 35 years old, obesity with a BMI of greater than 30, an unwhite race, a previous unexplained perinatal loss, where a child either is born with congenital anomalies, a child born with congenital anomalies, delivery of a fetus weighing greater than 9 pounds, or a previous pregnancy with gestational diabetes. Polycystic ovarian syndrome is as well a risk factor for gestational diabetes. Multiple gestation, a familial history with a first degree relative with diabetes mellitus or a gestational diabetes, a client's own birth weight less than 6 pounds or greater than 9 pounds, essential or pregnancy related hypertension, and the use of glucocorticoids in pregnancy. What are the nursing implementation that we need to put in place when providing care for a patient with gestational diabetes mellitus? We need to employ a diet, medication, and exercise together with blood glucose determination 4 times daily. We facilitate a referral of this client to a diabetic educator or a nutritionist. We observe for signs of hyperglycemia, glycosuria, ketonuria, and hypoglycemia. Patients with gestational diabetes will as well be required to perform a weight monitoring. We maintain a caloric intake as prescribed by a nutritionist with an adequate oral medication or an insulin therapy. We assess for signs of complications, for example, preeclampsia. Monitor for signs of infections, as these patients have a higher tendency of developing infections. Instruct these clients to report any burning and pain on urination, vaginal discharge, or itching, or any other signs of urinary tract infection. We need to monitor for signs of fetal distress. We schedule the visits every 2 weeks until they are 30 weeks of gestation, and then every week from 36 weeks upwards. The nursing care that we provide during the pre-delivery period includes an insertion of intravenous line for infusion of insulin and glucose-containing solution if indicated. On the day of delivery, we assess carefully the client's insulin needs and titrate the regular insulin and glucose-containing solutions based on the needs of the client to maintain a good maternal blood glucose levels. We need to monitor the blood glucose levels hourly, a fingerstick testing during labor with an aim of achieving between 70 to 110 milligrams per deciliter. We always position our clients on the left side to prevent a vena cava compression by the large fetus or polyhydramnios, which could cause a reduced placenta perfusion. We check for urine ketones hourly, especially if the blood glucose is elevated, and monitor the fetal well-being continuously using an electronic fetal monitoring system to detect for any signs of fetal distress. In providing nursing care during the post-delivery period, we use a sliding scale insulin due to a rapid fall in insulin requirements after delivery. Continue glucose infusions as needed based on the blood glucose levels to avoid incidences of hypoglycemia. We as well need to check urine for ketones for at least once per shift and monitor for postpartum complications that include preeclampsia, uterine atony, and infection. We should encourage breastfeeding as it reduces insulin requirements due to an increased metabolic demands and energy expenditure of lactation. To the infant, we need to assess for macrosomia, intrauterine growth restriction, hypoglycemia, hyperbilirubinemia, jaundice, polycythemia, any congenital anomalies, assess for infection, and features of prematurity. In the nursing plans and interventions to the infant who has been born by a mother with gestational diabetes, we observe for birth traumas, for example the clavicle fracture or cerebral trauma, we perform an heel stick for glucose assessment at 30 minutes of age, 1 hour of age, and as prescribed, and then observe for hypoglycemia and hypocalcemia. We begin a small, frequent feedings at 1 hour of age.